Hi,
Okay.
everybody. Thank you so much for joining us today. My name is Angie Peacock. I was a trained social worker and a therapist, but I'm also a subject of the film Medicating Normal. I volunteer doing outreach for the film and host conversations like this one today. This is our 39th interview, and today our guest is Dr. Jeff Ball. I love talking to Jeff. He's very down to earth. He's very real. He has a different approach than the general point of view. So I think you'll learn a lot today. So I'm going to read Jeff's bio really quick. Dr. Ball was trained clinically in several treatment modalities, but works primarily in a psychoanalytic relational model. His clinical focus has been directed toward personality and mood issues, including depressive and bipolar states. In his role as CEO of Psychological Care and Healing Center, Dr. Ball supervises, teaches, and consults. He presents his model and vision for mental health, both within the center as well as in the clinical and academic communities. Dr. Ball was a psychologist at the West LA VA hospital, and he worked for many years in private clinical practice. Dr. Ball has been on faculty at UCLA in the Semel Institute for Neuroscience and Human Behavior as an assistant clinical professor for many years. He's taught undergraduate and graduate level psychology courses, including psychopathology, psychological assessment, psychoanalysis, and law and ethics in psychology. As an assistant professor at USC, Dr. Ball taught undergraduate and graduate level courses in psychopathology and psychoanalysis. In his spare time, he enjoys traveling, painting, and playing basketball and tennis, as well as spending time with his family. His major life goals are to change the face of mental health treatment and to watch UCLA win a national championship in football. Unfortunately, the former is probably more likely than the latter. Welcome, Dr. Ball. I'm so excited to speak with you today.
Great, thanks. You're reading my bio. It just reminds me of how old I am. So
you have a lot of psycho talk in there, though. I was like tripping over the psycho this, psycho that. But quite an extensive resume, and you've done a lot and you've been in a lot of places. So hopefully we'll talk about some of that soon. All right. So can you tell us about? Well, I think we'll start off with this. I'm going to go off script. Tell us, like, growing up in the traditional medical model and kind of shifting to a different focus that led to PCH. Can you tell me about that, like how you came to be a psychologist with a different point of view?
Okay. So I trained at UCLA and in their clinical psych program, which was basically kind of based on a biopsychosocial model. So, as a psychologist, we focus more on the psychosocial side. But underlying the field has always been a strong medical emphasis. And the diagnostic manual is basically a medical model. Treatment philosophies. I still remember, even when I was taking the licensing exam, if they gave you a case that was someone who had depression, you would fail it if you wouldn't refer to a psychiatrist for medication consult. And so it's a field, and when I worked at the VA, I did private practice psychoanalysis. I was a professor, and I was working at the VA for 13 years, and 13, probably 8 years too many. And, and partially I say that because the care provided, both the psychological care and the psychiatric care, was really poor. I mean, it was pejorative diagnoses just passed down, over-medicated people, very little room or time for psychotherapy or staffing for it. And over the years, I started to really, and it was mainly from working with people and doing therapy. I used to teach abnormal psych. I taught it for 30 years or something like that. And I always hated the term because it's a pathologizing term just in the title. That, I would say when a plane crashes, it's not due to abnormal physics. And when people crash or people have psychological problems, it's not abnormal. It's part of normal human experience. And so that really came to frame how I thought about things. I used to lecture about personality disorders, and particularly borderline personality disorder. I don't believe in it anymore. And I don't believe in the whole personality disorder construct. What I've learned over the years is the diagnostic manual, which started off in the late 1800s. There were two diagnoses. There was something called dementia praecox or schizophrenia, and there was manic depression. And it's grown not for the better, to where I think DSM-4 had 500 diagnoses. DSM-5 is a bit fewer, but more spectrums, so they can put people under an umbrella of disorder. And the reality is that, all of them are, it's very heavily influenced by big pharma. And they've really gotten in bed with the whole medical profession and have promoted these. They basically were part of the construction of the DSM and creating a lot of these disorders. And not coincidentally, almost all of them have a medication that can be applied to them. So, what most people don't know is I think it's 97% of the diagnoses in the DSM, they have found no clear biological basis. They're basically arbitrary categories that, and it's basically, the definition of normal. It's defined by older white male physicians for the most part of what they think is normal and what they think is outside the bounds of that, which is very culturally biased, it's gender biased. I didn't take that call, by the way.
That's good. They can wait.
It's a really flawed instrument. I always say we use it for insurance purposes because you have to, but otherwise we don't look at people in that way. We don't give them these labels, even though they want them at times, because our culture is so geared toward kind of othering and pathologizing. And our center is really become defined. We don't accept the term mental illness. It's part of a medical view. I don't like the term disorder. And, I think what we're talking about are problems in human experience. And if I can share the screen, I'll show how I conceptualize these kinds of problems. Let's see. So here is something I've come up with, that's kind of the alternative to the current diagnostic system. And, I've always put normal in quotes because I don't really know what that means. There was an old story of Freud. In his career, he said he met one person who made it through all of his 5 psychosexual stages, which would be, the idea of normality. And he said he found him very boring. So,
Wow.
The idea again is there's something, you can't live in our culture with all of the divisiveness and complexity and stress and not have any kinds of these symptoms. So the way that I tend to look at it is this kind of layers of we don't diagnose people. We diagnose emotional and cognitive states and then treat those states to help people cope with them, basically. So anxiety, normal is whatever that means. I guess that's sort of our best days. Anxiety or neurotic states, again, we all get anxious at times, what used to be called neurotic states. Same with depressive states. You suffer a loss, you get depressed. That's a normal reaction to loss. What psychiatry pushed for many years was this chemical imbalance theory. That there was a chemical imbalance both in bipolar, what they call bipolar disorder, depressive disorders. The serotonin levels were too low, so they came up with serotonergic antidepressants. It's been debunked. There are no chemical imbalances. Chemical imbalances are created by the meds that are used, but not in a natural state. And so, all of these kinds of things. There was an article, the pandemic is a great example where I read several articles how the incidence of mental illness has increased so much during the pandemic. And there was one article that said 6 out of 10 young people are experiencing anxiety, depressive, and OCD disorders during the pandemic, with the implication that they all need treatment and they all need pharmacological treatment. And my reaction to that is I'm more curious about the 4 who haven't experienced those things.
Good point.
Because it's a normal thing. We have a 100-year pandemic. People are dying. We
Yep.
didn't know what we did in the beginning, so everyone was washing and wiping down everything. So OCD symptoms were very adaptive, being hypervigilant, checking things. Anxiety was a normal reaction, and feeling depressed and being locked in lockdown was a normal reaction. So again, to me, the people who are so numb that they didn't have any of these experiences, to me, are more of the problem. And so depressive states, another good example is I saw actually this thing on Twitter once where this woman was saying she spoke to her husband's psychiatrist because her husband had just died and she was feeling depressed. And the psychiatrist said, well, I can give you something for that. And she said, well, aside from the fact that I think it's part of what killed my husband, aren't I supposed to feel depressed? My husband just died. And the psychiatrist said, yes, but you don't have to. And I think that kind of captures, my view is you do have to. You have to go through whatever the process is of feeling depressed to come out the other end. And if you numb it, it just prolongs that. And I think that's what antidepressants do, is they numb people. Yeah. It's like if you have a badly sprained ankle, you can take painkillers to be able to run on it, but you're going to injure it more. Yeah. And I think that, to me, I think there's something going through. It makes people stronger if they can work through a depression as opposed to numbing it. Yeah. So depressive state, borderline states are one of my favorites. It's such a pathologizing diagnosis. And the diagnostic manual, DBT, for example, targets this borderline personality disorder. And they made it kind of a thing where it's not a state people go into. I think we all go into borderline states. What I mean by borderline is being extremely dysregulated, easily triggered, and not trusting other people. So it's which are the same symptoms you get with complex trauma. Mm-hmm. And so we tend to want to look at it as trauma rather than people. The problem with borderline diagnosis, people look it up on the internet. They see that they're very pathologized, and they're told that they're never going to be any different. That they might get a little better, but they're always going to be a borderline. Mm-hmm. And that hasn't been my experience working with people. Everyone I've ever worked with who had that diagnosis had some kind of pretty significant trauma, or they were a very kind of sensitive personality that reacted differently to trauma. And so, the idea is they go from 0 to 100 when they're triggered, as opposed to most of us go 0 to 20 or 0 to 10. Mm-hmm. But all of us have those triggers. I have those triggers that will make me see things in very black and white terms.
Just turn the news on and suddenly you're borderline.
Well, that's a great point. The only thing, I never gave advice to my clients, and I call them clients now because we're not a medical model. Patients are very medical model term. But I always used to, one thing, a piece of advice, and I never gave advice, but I would tell people to not watch local news. And I stopped watching local news 25 years ago, at least. And jealous. Part of the reason is it's designed to make people fearful. They will, if there's no child abduction in your town, they'll find one and they'll put it on there. There's a car chase or there's something. And it's literally designed to make people more anxious and fearful because it's easier to control people that way. And people then want the medications. Right. So, I just don't watch it. And I've stopped watching as much the national news because it's so depressing and it's so sensationalized. But anyway, so the whole borderline, I went on a real digression, but the borderline diagnosis is incredibly pejorative. It is another way of othering people. I have heard professionals say, I don't even like to treat people like that because, they're so difficult. Yeah. The reality is if you treat people's trauma and you help them understand it in context, they become less dysregulated. And we use DBT, we use mindfulness meditation, we use yoga in our center, and all are good ways of helping people regulate better. Yeah. And so, and also a good therapeutic relationship helps with all the attachment difficulties that come along with it, with that kind of mistrust. So we found people get significantly better. They don't carry that diagnosis anymore. after a while. Like I said, we don't use it. Dissociative states are another good example. All of us dissociate. You know, I always say if you drive to work the same way every day,
Yeah.
you don't remember the ride, you're dissociated. The extreme example is a dissociative identity disorder they call now, or used to call multiple personalities. And with multiple personality, it's a result of severe early, usually sexual trauma. It's usually delivered by a family member, somebody close to the person. They could be 3, 4 years old. And it is incredibly adaptive to dissociate and leave when that's happening to you. And that's where this develops from. What becomes a problem later in life is when it gets triggered, you know, and it's not appropriate to that situation. People have the same kinds of defenses against it. So they dissociate and they create other personalities, they leave. So what we do again is work on the trauma and help people to understand how they react in that way. And I have found people who have really learned to manage it and work with it. You know, you don't cure it, you know, it doesn't totally go, none of these things totally go away because you can't heal the human condition.
Right.
You can just help people learn to manage it in better ways. And same thing with psychotic states, you know, these things aren't a continuum. There's someone who was probably a psychologist now who was diagnosed schizophrenic, who used to do a talk, and he'd say, how many of you feel your cell phone go off in your pocket and it's not there? And that's a hallucination. All of us have had that experience. And, you know, again, under extreme trauma and stress, people will become psychotic. Now, there may be a biological mechanism that makes people more susceptible to that. But again, even the term schizophrenia is under a lot of attack these days. It's become a garbage category for anybody who's suffering from any kind of psychotic experience. And so again, we don't tend to label people with these things. I find labels incredibly damaging, particularly around psych, because they're very sticky. You know, if you have a physical disorder, you have cancer, and you're treated, you know, and you're in total remission, you haven't had it for 10 years, you're no longer considered a cancer patient. You get a schizophrenia label, you get a borderline label, it's with you forever.
Yeah.
Which is again why we don't put it down on paper anywhere that's going to follow someone around, these kinds of labels. So, and then those labels affect people. They affect how other people treat them, they affect how they see themselves. You know, so many guys I saw at the VA were misdiagnosed. But it, you know, went on for years, and they were medicated according to that misdiagnosis, and they came to adopt all the symptoms of those diagnoses if you're treated in that way.
Yeah, like a self-fulfilling prophecy almost. Yeah.
Oh, it definitely is. So, you know, we tend to try to treat people as competent adults, as partners in their treatment. And we have found that people really respond well to being treated that way. We also do a lot of healthy living approach, and where you hydrate, you eat healthy food every day, you do some kind of meditative practice, you do some kind of art every day. We have a full arts program. All of these things, you know, doing good therapy, you know, aerobic exercise is more effective than antidepressants and anti-anxiety meds. And anxiety meds are terrible. They're very addictive. They don't really help your anxiety in the long run. So we don't use them. You know, people have to, if they're on them, they have to taper off. Same thing with amphetamines. You know, kids are given amphetamines for supposed ADD. You know, everybody, according to the DSM diagnosis, has ADD. You read the diagnosis. And they're given these stimulants that are incredibly addictive. And the research has shown they don't improve academic performance at all. They help control people more.
Right.
So again, we don't prescribe those. We don't allow them. So, you know, that's sort of our general approach is really having a different frame, a much more psychosocial frame around looking at people. And we do use medication, but it's really adjunctive to the therapy. It's, you know, if someone has a bipolar diagnosis, they need some kind of mood stabilizer. And because you can't work with somebody who's manic. And same thing if someone is responding to internal stimuli and they can't sit and do therapy or do the other kinds of experiential things we have, a low dose antipsychotic is appropriate. Sometimes there's certain antidepressants that help with obsessive thinking. And so we'll use them, but the idea is not to use them long term, to use them in low as dose as possible. So
What you might not be aware of this, but what you're describing is Joanna Moncrief's model of drug-centered psychiatry, meaning we're going to give a drug that, kind of changes the behavior that we see rather than treating a diagnosis. So what you're saying is like the patient is agitated, we need them to calm, we will use an antipsychotic. It's not the person has schizophrenia, give them an antipsychotic. You know what I mean? Like it's a drug-centered approach rather than a diagnosis label approach.
Well, and Robert Whitaker talks about a World Health Organization study that showed that those treated for schizophrenia in developing countries do better than those in the Western world.
Yeah.
And the reason is they have less access to those meds, so they're given more acutely, shorter term, whereas here, people are given them basically to manage them, so they're overly tranquilized, they're kept on them forever. Yeah. I remember asking a psychiatrist at the VA, we had guys in their 60s, 70s who'd been on these meds for years and years. I said, do you ever think of giving them a drug holiday and taking them off? Because they haven't shown any symptoms for years. And she said, well, no, but because if they end up having symptoms, it's going to make my job harder to kind of maintain it. Yeah. And that was a real typical attitude.
Yeah. I see it sometimes the family is uncomfortable with the way the person's acting, but instead of saying like, well, maybe my son is just different and he's a little strange, he does weird things, but he's like super creative. It's like the family wants to medicate the child, but it's really their discomfort. The kid's fine, like he's like, I'm living my life. But yeah, it's kind of backwards.
I think that's often the case, that medications are given to make other people more comfortable than the person themselves. Yeah. We've had the experience where people have been in other treatment centers and they're they've managed them because they're so over medicated, they can't be difficult to work with. And we just don't believe in that. Quality of life is too important. And if you're on strong antipsychotics, there's not much quality to that life.
Definitely not. So we are running out of time quickly because we're just having a good conversation here, but I want to get to this one question. I listened to one of the videos on your website and you said we have a 0 cure rate because you can't cure the human condition. So can you talk a little bit more about that?
Sure.
Wait, can you undo share your, there we go. Yeah. Okay.
Like I'll have families come in, they'll say, how many people do you cure? And it's true. That's not how we look at things. That the idea isn't that you never feel pain in this life. And I think that is the focus of psychiatry a lot of the time, is if you're feeling something, you don't need to, you don't have to. And, aside from the fact that the antidepressants have such horrible side effects and cause iatrogenic damage. So new disorders come up, they're created by these meds. So, our view is that we help you live a more contented life. No one's happy all the time. But hopefully you find a measure of kind of contentedness. And that's, like I said, there's no cure for the human condition. It's part of what makes us, and it's like, if you don't feel pain, you can't really feel pleasure very well either. So, it's really a different kind of view as opposed to, other parts of medicine. It makes sense. If someone's in pain, you want to make that go away, but you usually know what the cause is. In psychiatry, they have no idea what's causing many of these things. And there was a great study, there are all these millions of dollars put into studying suicidality and looking for some genetic link and all of this. There was an epidemiological study that showed, it was over 20 years or something, if you raise the minimum wage by $1,
I saw that.
the suicide rates go down 5%. And if you raise it $2, they go down, I think it was 7 to 10%.
Yeah.
So again, it's the way that our world is that creates so much, homelessness, poverty, joblessness, those make people depressed.
Yeah.
Giving them a pill isn't going to help them get a job.
Yeah.
And so again, I think we need to put our focus on not only the whole person and not put pathology within people, but looking at the whole system that people are functioning in and trying to find ways to remediate that system.
Well, that's interesting because I was going to do a PhD in psychology, but I shifted to social work because they had that focus on the context, and I felt like psychology kind of left that out. So it's interesting that you came to the social work side on that.
Well, what's interesting is one of my closest friends in the field, Ross Ellenhorn, is a doctor. His doctorate is in social work, and he's actually kind of turned me on to a lot of these ideas. Even though I've always had a real kind of psychosocial bent and looking at family systems and how different systems impact, but I think it has broadened to where I think we have to look at the whole cultural system as well.
Totally. So you have a screening coming up, and we'll have Doctors Westby Trent and Dr. Pilko. Can you talk about your upcoming screening and kind of what you think we'll be discussing, just so people in the audience who, if they'd like to join us, what they'd be in store for besides what you said today?
Sure. It's funny, over the last, PCH has been open about 11 years. I found a lot of the views that I have were seen as super controversial. I didn't believe in the term borderline. I didn't believe in a lot of these things, a lot of the medications. It's interesting, the field in the last 10 years has come around where there are many more people in line with that kind of thinking. When I screened, it was Bo Bartlett, my friend, who's the artist who, included me in the screening for the film. I was just sort of struck by how much it mirrored my experience in the field over the past years, and how it really captured just how the system, the medical model of pathologizing and medicating is so damaging to people much of the time. Again, I think there are appropriate uses, but most of the uses are not appropriate out there. And so I was really encouraged, and we have talked about screening it for all of our clients as they come into the program. So so many people, they want these labels, they want these meds because they've been sold this. You can't watch television without 3 or 4 pharma ads coming on every hour. Pharma ads, and they always have their side effect disclaimers at the bottom, which are gone over very quickly, but those are drug effects, and they're very negative effects. And if there's an alternative to using medications, that's what we do.
I love it. So for everybody in the audience, Nicole is going to post a link for tickets, but their screening is October 28th, 5:30 Pacific. That's Los Angeles time. So we will have a link to tickets. And before I let you go, I have one more question. I just read this last night. The DSM-5 TR is coming out in March. How do you feel about that?
I haven't owned a DSM since DSM-3.
I'm so proud of you.
So, I mean, we have one obviously at PCH because we have to use it for insurance, but I think they're pretty good doorstops myself.
Oh God, you're just cracking me up because social work school, they made us buy one, and I just protested. Like, I was like, I can't do this, it's against my ethics, I don't want to give them my money. So I bought one from a fellow student really cheap, and then I got a PDF for free, and then when I left, I sold it and took the money back because I was like, I just cannot in good faith like give this people money. I just can't. Okay.
What does TR stand for?
I don't know. It's like, it's their, an amendment. I guess they got to add some more disorders. I don't know. I haven't seen what the new changes are going to be. I just saw it last night and was like, oh no, here we go.
It's really, again, it's a moneymaker. It's another, but it's a system that's really outdated. It doesn't take context into account almost at all.
Yeah.
And so, how do you label someone and diagnose them without looking at the context of where that label came from? And that's my problem with it.
Totally. Well, thank you for joining me today, Jeff. I wish we could spend more time, but you got lots to do, and things to change and people to be there and present for without labeling them. So we appreciate everything you do here at Medicating Normal, and we can't wait for your screening coming up, and we hope we'll sell lots of tickets so we can have a really engaging discussion. So thank you from
I think
us.
it'll be great. We have Dr. Trent, who's our clinical director, who's incredible, and Dr. Pilko is my friend, who's our one of our psychiatrists who runs our more acute program. And we all have a very similar philosophy of using medication in the service of psychotherapy, but not as a standalone solution to anything.
I love it. This is the way for the future. So yes, please join us at that continuing conversation. The link is in the bottom of the comments. So to everybody else, thank you for joining us today. If you haven't seen Medicating Normal yet, like I said, check our website. There's a PCH screening listed there. We also want to mention that we are going to be on PBS in January. So if you don't see it now, you're going to have to wait till January. But we're really excited about that. We've been completely backed by our community. You guys have donated to help us make that happen. We're just so grateful to all of you. Also, we release videos on our YouTube channel. We're on all social media platforms, so please like or follow us if you can. That really helps us. And I think that's it. Do you have any closing thoughts, Jeff, you want to leave with everyone?
You know, I don't know if I can find it as quickly enough.
It's okay.
No, I'll save it for the screening.
Okay.
So.
Yeah, then you got to come. That's a teaser. All right. All right. Thanks, Jeff. Thanks, everybody in the audience. We'll
Thank
see
you
soon, and we hope to see you at the October 28th screening. Bye-bye.
Bye-bye.